So hi and welcome back. This video will cover another part of the arrhythmias known as conduction blocks. So as you can see from the cartoon, the blocks can occur in multiple regions within the heart. So you could have a sinus node block, which you can see is actually depicted here by this green box right there, as a block to the sinus node. And you could have an AV block, again here at the AV node. You could have bundle branch blocks, fascicular blocks, and so on. And so we're going to talk about some of the common types of blocks that you'll be seeing. So I'm going to start with talking about AV blocks. So in an atrioventricular block, again that's occurring over here by the AV node, and so the output from the AV node is being affected. And we can see actually various types of AV blocks that occur. They give us very distinct patterns on an ECG. So there's, we divide into what we call a first degree, second degree, and third degree block. And the second degree is broken down into something called a Mobitz I and Mobitz II. And then we'll discuss bundle branch blocks and Hemi blocks and how can we assess that on an ECG. So the first degree block, so we're looking over here to the left, the criteria for a first degree block, AV block, is the PR interval has to be greater than 0.2 seconds. So from my first video, I discussed that the PR interval should be between 0.12 seconds and 0.2 seconds. 0.2 seconds is actually one large box. So let me just highlight that so again we have our reference. So here on the left, I'm drawing in, just one box there. That's a large box. The width of that is actually 0.2 seconds. So if that's 0.2 seconds, we can actually use that as kind of a reference to analyze the PR interval. Remembering that the PR interval is from the start of the P wave to the start of the QRS. So if we take our example here, here's the start of the P wave right here, and then here's the start of the QRS. Okay, and you can see that this, the length of this, all right, that PR interval is definitely larger than one large box or greater than 0.2 seconds. And in first degree block, every single PR interval should be about the same, and they should all be greater than 0.2 seconds. Now the reality is some ECG, in the ECG, you might see in some leads the PR intervals are not exactly the same in all the leads, but we would be taking really the longest one, the longest PR interval that we find. And that would be, again, extended beyond 0.2 seconds. And so, we can see in this particular lead that it's extended and it would be a fixed PR interval. And so that's a first degree. Now, in a second degree AV block, we have a Mobitz I and a Mobitz II. A Mobitz I is also referred to as a Wenckebach. And so if we look at this ECG, all right, you can see here, it's already bracketed for you. But you'll notice in the first one, all right, this one right here, that first complex, you'll notice the PR interval. It actually looks somewhat normal. But then when you see the second PR interval that follows it right over here, that actually looks longer. And then by the third PR interval over here, it's even longer than the other one. So it continues to increase. So the PR interval is gradually increasing in duration until finally what you see here, this is actually a P wave with no QRS complex at all. So it's just what we refer to as a dropped beat, but that's a P wave that you're seeing there with no QRS following it. And then you'll notice the next thing that happens is the complex starts over, and this complex here looks exactly like the one we first saw, which has essentially a normal PR interval. It looks like an overall normal complex, and then it's going to gradually lengthen and then drop. Okay. Sometimes this is also referred to as regularly irregular because there's a regular sort of pattern to it, but it's irregular. Mobitz II. Okay, now in a Mobitz II, again, we're looking at that PR interval, and the PR interval, you'll notice here that the PR interval in this complex and this complex here, and even over here, do not actually seem to be greater than 0.2 seconds. In fact, it looks like a normal PR interval, But what you probably notice is this guy right here. That's a P wave. And that P wave is, again, not followed by any QRS complex. So this is actually another drop beat. Unlike in Mobitz I, where the PR interval gradually lengthened and then dropped, okay, that's very characteristic of the Wenckebach. In Mobitz II, you have almost essentially a normal PR interval and then just a dropped beat. And so in comparing, Mobitz I to Mobitz II clinically, Mobitz II has a poorer prognosis relative to Mobitz I. Now, in the third degree, a third degree is also referred to as a complete heart block. And so a complete heart block, if you look at this ECG here, all right, it's labeled all the P waves for you, which is helpful. And again, this may take some practice to notice this, but you also would want to use, a rhythm strip. And what you'll notice is that the QRS complexes, it almost looks like, if you were to look at this one right here, it almost looks like there's a little P wave that precedes the QRS and kind of initiated that wave, even though the QRS, again, doesn't look entirely normal here. It looks pretty wide, okay? But this wide QRS should sort of tell you something first off. The wide QRS means it's probably not being initiated in the normal electrical conduction pathway, first of all. And there's usually a regular sort of marching rhythm to the ventricle. And in fact, if we were to keep following it, we'd probably continue to see sort of a regular ventricular beat, which would be fairly slow, actually, because the ventricles, if left to beat on their own and keep the pace, it's generally slower than the SA node. The SA node, located in the atrium, right, which would be giving us our P waves. And so you can see the P waves. And if you were to actually measure out these P waves, and you notice the P waves just occur wherever. In fact, you can see this P wave almost occurring almost on the QRS, one that fell right before a QRS, one that seems to fall on the T wave itself. And what this is telling you is if you were to measure the distances between these P waves, that's also very regular. So these P waves are actually occurring at very regular intervals, kind of marching along at a regular rhythm. And so would the ventricles. But what you'll notice is that the QRSs and the P waves are not actually associated with each other at all. The P waves seem to be occurring randomly all over the place, but they're actually, if you measure it, occurring at distinct intervals, at regular intervals normally. So what this means is that the SA node is firing of its own accord. The AV node, or below the AV node, essentially in the ventricles, is also now has its own pacemaker firing of its own accord, and you have a complete block or a complete dissociation between the atria and the ventricles. They're both essentially doing their own thing and have their own timing. And so sometimes this is referred to as I've written down here, AV dissociation, where there's dissociation between the atria and the ventricles. And this would be more of an emergency in some cases, that we actually have to use pacemakers to reset the timing, because the timing is critical. We want the atria to be able to contract, give the ventricles enough time to fill up, and then the ventricles will contract to follow that, and that gives us our normal cardiac output and so on. In this case, you could have an atria, when it contracts, might be contracting against a closed tricuspid valve, for example, because at that moment the ventricle is also contracting, because they're not coordinated, and that could cause backup. So you might even see in clinical cases where when the atria contract, if it's contracting against a closed tricuspid, you could actually see large pulses when that's occurring in their neck veins, because there's no valve separating the atria from the veins in their neck. And so you might see, if it contracts hard against the closed tricuspid valve, that sends the blood and pulses it backwards instead. And you can sometimes see that in the pulse as well clinically. Now, if we move down a little bit further from the AV node and we go to the bundle branches, so remember that it goes from the AV node to the bundle of His to the left and right bundle branches. The right bundle branch supplies the right ventricle, and the left bundle branch supplies the left ventricle. Now, a bundle branch then means we're blocking one of the bundles, the right or the left. Now, in a right bundle branch, we're blocking the branch that's going to the right ventricle, which means the ventricular tissue is going to depolarize slower than the left ventricle. Because what's normally going to happen here is that you're going to have depolarization coming from here this would be our AV node, and then here's our bundle of His right here, and then you have branch points, so that's our right bundle branch, and this would be our left bundle branch going in this direction. And so this little green box is indicating blockage of the right bundle there. So what we have is normal conduction through the left bundle branch, because that's not blocked. And so that conducts through the left ventricle at a normal rate. And what ends up happening is, since the right's bundled, there's a delay in getting the signal to the right side of the heart. So what happens is, as the left side depolarizes in through the myocytes, remember all these myocytes are connected by gap junctions, so it depolarizes the left ventricle, and then it moves slowly through these gap junctions of the myocytes over to the right ventricle. And that slows down the time it takes to actually depolarize the entire ventricle. So again, there's a delay in depolarization of the right ventricle. So if you recall, a normal QRS should be narrow. The duration of it is less than 0.1 seconds. This would be a prolonged duration. And by definition, a prolonged duration of the QRS is actually greater than 0.12 seconds. So again, it takes longer. So should we see an increase in the QRS duration? So it should be wider. We're usually can find, if we're assessing bundle branch blocks, we look at the precordial or the chest leads. So that's why in this example over here to the right, it shows only V1 through V6, which are our chest leads. Now in a right bundle branch, we're actually looking at really V1 and V2, and then usually at V5 and V6. And so in V1 and V2, since they're located more towards the right side of the heart, what you're seeing here, again, this is an increased QRS duration. And you'll notice it has this sort of characteristic shape, which I'm going to draw over here for you, where it goes up, it comes down, goes up again. Okay, now this kind of looks like an M. Sometimes it's also referred to as these bunny ears. And so you can see this bunny ear appearance. You can see that it has an R wave, then an S, and then another R. So we refer to this as our first R wave, then there's an S, and then there's an R. We call that an R prime. So it's an RS R prime formation. And you can see that usually in V1 and V2. So if you look at V2, it's the same thing. You can see an upward deflection, the R, the S, and then another small R prime following it. So this is sort of a classic appearance of a right bundle branch block. And if you look at V5 and V6, in V5 and V6, usually since these are the reciprocal leads, or the leads that are kind of opposite to V1 and V2, they would usually show a deeper S waves. Okay, usually deeper S waves, or sort of the opposite appearance of what you see in V1 and V2, which would look kind of more like a W instead of an M, if you will. But it should usually have, more of an S wave to it. Okay, which again is not normal for those particular leads. They should usually have, good upright R's. And lastly, just to kind of give you an idea about the shape of this bunny ear appearance. Well, the bunny ear appearance, normally we have an upward deflection initially in V1 or even V2. And then it goes downward as it's moving towards the left ventricle and away from V1 and V2. And then as it swings back around to depolarize the rest of the right ventricle, you see that next peak of that R prime. So that R prime really is the delayed right ventricular depolarization wave. And so it gives that shape, that characteristic RS-R prime shape. In a left bundle branch block. So the left bundle branch is the one that goes towards the left ventricle. And again, by the way, this division of the bundle branches occurs in the septum. So we have our AV node over here, and then this would be the right bundle, and you'll notice that the left bundle branch is occluded there. And so that means it's the opposite of what we just talked about. The right ventricle is depolarizing in its normal, fairly quick duration, and then it's going to spread via the myocytes and those gap junctions towards the left ventricle. So the same principle applies in that you have an increase in the QRS duration greater than 0.12 seconds. Okay, and so you should see it wide. And we're looking again at really V5, V6, and V1 and V2 again. And in V5 and V6, right here really is showing this sort of characteristic appearance. something they call a notched R wave, or even kind of like a plateaued or flattened R wave, where it comes up like an R wave, and then it's kind of plateaued a little bit and comes down again. And it may be notched. It may actually come down a little bit like this and look a little bit more notched. And ultimately, it's kind of like looking at small bunny ears or a little bit of an M there, but it's happening now in the left ventricle instead. And so, this would be indicative of a left bundle branch block. So a wide QRS plus this notched or broadened R wave that you'd see. And then the reciprocal of that would be in V1 and V2, which would show these deeper S waves. All right, which you can see these deep S waves occurring there. So if we have these, large, thick R waves in V5 and 6, usually on the reciprocal or the opposite lead, you'd see the reverse of that essentially. And then the last thing I want to point out, which I neglected to point out on the previous slide, is that included with both the right bundle branch block and the left bundle branch block, you usually have repolarization abnormalities, meaning typically some inversion of the T waves. And so you can see that over here. All right, in V6, you can see that the T waves are inverted there. So a widened QRS in both cases, and then you'd also have the RSR prime, which you'd see in a right bundle. In a left bundle, you'd see sort of a notched R wave in V6 or V5, and then in both of them you'd see repolarization abnormalities with like T wave inversions. Now, in a fascicular block, so fascicles are actually essentially more branch points, but the fascicles only come off of the left bundle branch. So again, here's our AV node, and then here's the bundle of His, and then this is our left bundle over here, and here's our right bundle. In the left bundle, we have another branch point right here, and that's going to be our fascicles. And so what you have is you have a little septal fascicle, which is the tiny one over here, right there. And so that gives off a little fascicle to the septum. And then you have what we call an anterior fascicle, all right, and then a posterior fascicle. And this is the anterior fascicle right here, which is blocked. So left anterior fascicle, and then the left posterior is going down behind this way. Now the left anterior, as its name kind of suggests, is in the left ventricle. It moves in the anterior aspect of the ventricle, laterally and inferiorly, because that's the direction it's moving in, is laterally and inferiorly. And it does connect, ultimately it would connect with the posterior, and they would kind of meet towards the apex, if you will. And in this case, if there's a block, that means if there's a block in the anterior fascicle, that means the signal goes through the posterior fascicle and then swings all the way around to where it should be meeting up with the anterior, but it's not, so it swings further around than it normally would. And in this case, a couple of things with a fascicular block. We're looking at essentially just the limb leads, and the QRSs are of normal duration because it's basically following most of the pattern, and even just going through the posterior fascicle there is very, very quick. So the QRS duration is normal, so it should be less than 0.1 seconds. And you'll notice in this example here, since it's going down the posterior aspect of it and swinging around towards the left to go up through the anterior, where they meet essentially, where their junctions are, that creates actually a mean vector that points really in this direction. All right, it points in that quadrant, which you can see actually drawn for you in the blue arrow down here. So it actually causes a left axis deviation. So in other words, if you have a left anterior, what they refer to as a hemiblock or a fascicular block, that creates left axis deviation. The QRSs have a normal duration as well. So if you have just a left axis deviation, which is what I wrote over here, left axis deviation with really it's kind of an assessment of exclusion, because you have to kind of rule out if there's hypertrophy and the anatomy of the heart and the position of it and so on. But if you were to rule it out, all other causes for axis deviation, and you just have axis deviation, you could comfortably say that this might be a left fascicular or a left hemiblock. And that's all you're looking for. So once you've assessed axis deviation, if it's the only thing you can find, then you could suggest that this is a fascicular block. Now, left axis deviation, if we take a look at our limb leads again, because that's where we assess axis, where we're really assessing the mean electrical force going through the ventricle. You'll notice that 1 is upright, and 1 and 2 should be, under normal circumstances, be the most upright QRSs. In this case, that's not what's happening. You see it's upright in 1, but it's really mostly downward going in 2, but it's upright in L. Even though it's small, it's a small amplitude, it is upright in L and it is upright in 1, but there's essentially small amplitude in every single lead here. So it's upright in 1 and AVL, and it's more downward going in 2, which means it's actually somewhat moving away from 2. And I can't really see any good isoelectric complexes here or good biphasic waves. It looks like it's moving away from 3 and away from AVF. All right, so this definitely suggests, without being calculating out specifically, that it's in the negative 30 or greater, or I should say negative 30 or less than, or more negative than negative 30. So therefore, a left axis deviation. Right fascicular block, it's ultimately the same principle. Narrow QRS. The only difference is now the posterior is blocked, and so the conduction goes through the anterior leg of it, and you'll notice that creates a vector, a mean vector that points in that direction. So that's what you see down here in this quadrant. And so if it's pointing in that direction, that's a right axis deviation. And so right axis deviation with a narrow QRS and no other explanation for the axis deviation, then this is a right fascicular or a right hemiblock, otherwise what we refer to as a right posterior, excuse me, I shouldn't say right posterior, a left posterior hemiblock with right axis deviation. All right, so here we have, let's take a look at our right axis deviation. So 1, somewhat actually biphasic, but it's even slightly negative going here. You see it's upright in 2, mostly upright in 3, and mostly upright in F. And yeah, it's downward in AVL, so it's going away from AVL, and it's going away from, primarily going away from 1 there, because the S deflection is greater than the R. And so this means that since this isn't perfectly isoelectric, it's not exactly 90 degrees to it. It's slightly going away from it, which means it's probably greater than 90 degrees, which makes it a right axis deviation. Now moving on from the blocks, we have something referred to as pre-excitation. So this is essentially the opposite. Whereas in the blocks, we had some kind of conduction obstruction, which causes delays for the most part, like a PR interval delay or an increase in the duration, an increase in the duration of the QRS, if there's like a bundle branch block, for example. In pre-excitation, this is where the PR interval is shorter than it's supposed to be. So it's less than 0.12 seconds. All right, so that makes it pretty close. So there's not enough of a delay between the atria depolarizing and the AV node before it depolarizes the ventricle. So we call that pre-excitation. And there are a couple of different forms of it, but one of the most common ones is Wolff-Parkinson-White, or WPW. Wolff-Parkinson-White is essentially a reentry loop, but a very large reentry loop. So we've talked about reentry loops wherein you have small little kind of racetracks, if you will, in multiple spots in the atria when we're talking about AFib, or around the tricuspid when we're talking about atrial flutter, or within the AV node if we're talking about PSVT, for example. This is also can create this electrical racetrack again. And what's happening here, though, is this sort of electrical current, the circular current that's occurring here, is occurring from the atria. I'm going to draw it over here. I'm going to draw a little circle from the atria, from the ventricle, and back again. So it's actually a larger loop, and it can go in either direction. And so let me explain that in a second. So let's quickly look over here at the ECG. Again, the PR interval will be short. So if you look at the PR interval here, this is very, very short, because right after the P wave, it seems to go right into the QRS complex. Now, Wolff-Parkinson-White, this is very characteristic finding right here. You can see it again over here, where there's an upslope. generally speaking, with the QRSs, you shouldn't see an upslope. It should go directly upward like a 90-degree angle. But here, instead, we're seeing this more gradual upslope here. And that's referred to as a delta wave. So that's a delta wave. Now, when it comes to Wolff-Parkinson-White, the delta waves may not be evident in all the leads. So when you see a shortened PR interval, you have to kind of examine a lot of the leads to see if you find those delta waves. They may appear in more than one lead, or multiple leads, and may be easier to see. But you should always look for them carefully, especially if you suspect this is a short PR interval. And if you see the delta wave, we have what we call Wolff-Parkinson-White. Now, in terms of the physiology of that, what happens is you have something called the bundle of Kent. So I'm going to come back to the cartoon over here. The bundle of Kent is actually an accessory pathway here. And that accessory pathway allows communication of the atria into the ventricles directly without going through the AV node. Because normally it should go through the whole atria and then funnel to the AV node. And at the AV node, we have our pause to allow appropriate filling of the ventricles, and then the AV node fires and it follows the conduction through the septum and so on. In this case, you have this extra, accessory pathway called the bundle of Kent. And so as the atria depolarizes, that electrical current can actually move directly into the ventricles. Now the thing is, it usually, when it's entering into the ventricular myocytes there, and it's not following the normal conduction pathway, which has the bundles and the Purkinje fibers, which move or conduct much faster. So what happens is it excites the myocytes there, and it starts to move slowly through the myocytes, through those gap junctions, and again, this is relatively slowly, through the myocardium there, not through the normal conduction pathway. And so what you're seeing here is this little blip, this delta wave. That's actually the initiation through that bundle of Kent, where it's a little bit slower, which is why it's a gradual upslope. But then the AV node, which has also been signaled at the same time, essentially, the AV node then, when it fires and conducts, it zips through the septum there, following the normal conduction pathway, which is very fast, and essentially connects with the slow conducting pathway going through the bundle of Kent. And so that's when you see our normal QRS appearance again. So that little gradual delta wave at upsloping there is really that accessory pathway, which is slower, meeting up with the normal conducting pathway. Not all cases of pre-excitation are going to have a delta wave. Lone-Ganong, is another type of pre-excitation where you can have a decreased PR interval and no delta waves. This next section is about myocardial ischemia and infarctions, and what we would normally or characteristically see on an ECG. What kind of findings are there? Because this is, one of the things that we need to be versed in, especially since patients, when they're presenting with chest pain, they all get an ECG. And so we need to be able to understand and interpret quickly what the ECG is showing us. And so to start, we'll talk about the infarctions. And infarction actually means that there's dead tissue. So this person had an MI or myocardial infarction where there's dead tissue. And so the question is, how does that represent, or how does that display itself on an ECG, and how can we interpret that? So there's really three stages. What happens is, when the heart tissue is actually dying, it can disrupt some of the electrical activity in the heart in a very characteristic way. And so usually some of the features are this transient T wave peaking and then an inversion. And that happens very quickly. So if you look down here at the cartoon, there's a peak and then an inversion. And that happens pretty quickly. And then what you see is in the next one, in part C here, there is a reduction in the amplitude of our QRS, and then there's this very characteristic ST segment elevation. And ST segment elevations are usually seen in what we call a full thickness myocardial infarction, meaning usually the entire thickness of the wall has been affected under most circumstances. Then what you have here in case D is the formation of something called a Q wave. And just to remind you guys that a Q wave, by definition, is a downward deflection that comes before the R wave. So it's defined as a Q. And there are normal physiologic Q waves, which we'd usually see in, say, V5, V6, or AVL. Usually the left lateral leads is where we might see that. and they're tiny. They're usually not larger than, say, one little box. Now, a Q wave is useful diagnostically for several reasons, but it's different from the ST segment elevation. The ST segment elevation can last for a few hours to days, and it's a good marker of an acute infarct. And usually it will recover back to normal with no prolonged ST elevations. However, the formation of the Q wave that can persist under normal circumstances for the rest of the patient's life. And so it can actually be sort of a marker of old myocardial infarctions if you're looking at an ECG. So if you see those Q waves, we don't normally use Q waves as an indication of an acute or ongoing infarction, however. So with a Q wave, any leads that show these Q waves, and the Q waves again have to be pretty deep. They have to be larger than a tiny little box, one of those small boxes. And in general, a Q wave to be more pathologic, it has to be the depth of the Q wave usually has to be about 25% of the total length of the QRS. So usually about 25%. And then it also has to be found usually in what we call contiguous leads, or leads that anatomically are connected to one another, like 2-3 in AVF. So to see a Q wave in 2-3 in AVF means you probably had an old inferior infarct. Or in 1 AVL, V5, and V6, you have Q waves there. They all correspond to the left lateral side of the heart. So that's what we mean when we say contiguous leads. Now, to understand the Q waves, this cartoon over here is showing you the normal, which is A, the normal heart, and you can see the arrow here. It's black, and so you have to look closely. That shows us our normal mean electrical force going through the ventricles, which usually points leftward, as discussed earlier. And we have our lead over here. So normally we would see an upright deflection, which they're showing you. All right, so there's an upright deflection as the mean electrical force is heading in that direction, or more towards it. However, in B, though, this is indicating infarcted tissue. So this is dead tissue in the left ventricular wall, and you'll notice it's the full thickness of the left ventricle there. And what you notice is, again, we're looking at lead 1. You'll notice that the mean electrical force is actually moving away from lead 1 now instead of towards it like it normally should. And the reason it's moving away from it is because dead tissue doesn't conduct electrical activity, or doesn't have any electrical activity at all. It doesn't conduct electricity. And so the axis now is skewed away from it towards the electrical conducting tissue. And so therefore now, since it's moving away from lead 1, you see a downward deflection. So for us clinically, it's, as I sort of suggested before, is that anytime you see leads with Q waves, it tells you anatomically what parts of, or approximately anatomically what part of the heart they have the dead tissue. So again, if it were lead 1, that would probably also be affecting lead AVL or V5 and V6. So those would be the contiguous leads, and they would show Q waves. And that would suggest the left lateral wall of the ventricle, the left ventricle. Whereas if it were 2-3 in AVF, that might suggest more of the diaphragmatic surface of the left ventricle, or even the right ventricle. So that would be how we assess myocardial infarction. There is also, ischemia, and when it comes to ischemia, we don't normally see ST segment elevations. So if we take a look at the cartoon down here, we use our PR segment as our baseline. All right, that's our baseline. And so the ST segment under normal circumstances should be at the same level as that PR segment there, okay, because that's our isoelectric line. So they should be the same under normal circumstances. Over here, though, here's our PR segment. It should be where the red dotted line is, but instead it's elevated to here. So that's our ST elevation, which indicates an infarction. And then over here, if we look at this, here's where it should be, and it's below that level. Now, since it's below the baseline there, we call that an ST depression. So an ST segment depression usually indicates ischemia. Okay. Now with ischemia, that usually means that there's not entire full thickness that's been affected in most cases, but usually the endocardial surface of the heart that's been affected. The endocardial surface of the heart, just to remind you guys, that's the innermost lining of the heart here, which I'm just going to highlight in red there. That's the inner lining, which is usually the most prone to ischemia. Okay, so that's the site that where we'll usually see that, and that'll usually show in ST segment depression. Now, what's clinically useful in interpreting the ECG is to get an idea, or at least a rough idea of the arteries that might actually be causing the problem, or where there might be some sort of an occlusion. So remember that the heart receives its blood supply through the coronary arteries. And so the coronary arteries come off of the aorta, the initial portion of the ascending aorta there, right above the aortic valve. And you can see here we have the left circumflex, okay, heading towards the left ventricle. And then here's the descending, or the left anterior descending, which actually goes along the septum there that separates the left and right ventricles. And they're connected, which is hard to see up here, but they're connected by the left common. So you have the left common carotid, which branches into the left circumflex, which wraps around sort of the left, supplying the left atrium and the left ventricle, and moves posteriorly. And then you have the left anterior descending, which again descends along the anterior aspect of the heart there, along the septum that separates the two ventricles, and supplies blood to the 2/3 of the thickness of the septum, as well as to the left ventricle and some to the right ventricle. The right coronary artery over here is kind of tucked away behind the pulmonary artery. Okay, and you see the right coronary artery will supply the right atrium and the right ventricle. It also wraps around, as you can see, it wraps around the heart there. And in people who have what they call a right dominant heart, it gives rise to the descending, posterior descending artery. That's typical for about 80 to 85% of the population. 10 to 15% of the population might be what we call left dominant, which means that descending comes from the left circumflex instead, or the left coronary. So that's the basic anatomy of the coronary vessels. So on an ECG, what that correlates with is, again, where the leads are kind of in association with it. So for example, in leads 2, 3, and AVF, which are our inferior leads, that's looking at the diaphragmatic surface, and that's really associated with the right coronary artery, which again feeds like the right ventricle and part of the septum, the posterior third of the interventricular septum there. So we can make some judgment call on it, and again, it's not foolproof at all. Okay, other workup would need to be done, of course. But leads 2, 3, and AVF, if you see ST segment elevations there, that might suggest right coronary involvement of the heart on the diaphragmatic surface there. Now the lateral leads, 1, AVL, V5, and V6, shows the left lateral surface, which really correlates pretty well with the left circumflex artery, which you can see over here. Okay, so the distribution of blood to that left lateral surface of the heart there, provided by the left circumflex. And then the anterior, like V2, 3, and 4, essentially, they correlate well with the left anterior descending, which is this portion right here. That's left anterior descending, which is on the anterior aspect of the ventricle there, and again supplying the 2/3 of the interventricular septum, the left ventricle, and parts of the right ventricle. So that would tell you that there might be sort of an anterior infarct. And then finally here, the posterior, we look at V1. Now posterior is a little bit tricky because we usually use a 12-lead EKG or an ECG. We could use more leads, but since we typically only use 12, how we'll usually evaluate the posterior, a posterior infarct, is based on looking at V1 in the chest lead. Because what happens is the right coronary wraps around, it's primarily coming from the right coronary here. V1 will usually demonstrate or be opposite, or it would be the lead that's opposite that, and what it'll do is it'll show you the reciprocal of an ST segment elevation and show an ST segment depression instead, since it's on the opposite side of the heart there. And so we usually see ST segment depression. Instead of a large Q wave, instead we might see a large R wave. So it would show sort of the opposite finding. If you were to put a lead directly on the person's back there, it would show in that lead that overlies the posterior aspect of the heart, it would show ST segments, elevations or Q waves as it would normally be seen as we see with other leads. But since we don't have that in most of these ECGs, we look at the V1 and we look for that reciprocal kind of change. It's often associated with the 2, 3, and AVF because the right coronary usually supplies the posterior aspect of the heart there. And so you can look at 2, 3, and AVF and you can see ST segment elevations. And so if you see ST segment elevations in 2, 3, and AVF, take a look at V1 and see if V1 has an ST segment depression as well as, a large R wave. And that might give you some information that the posterior is involved as well. So again, to kind of give you some example here, looking at the leads, you say, all right, well, 2, 3, and AVF has ST segment elevation, so therefore this is probably the inferior diaphragmatic surface of the heart, supplied by the right coronary vessel. And same thing with 1 AVL, V5, V6, the left lateral surface of the heart, and so on. Now remember, there could be combinations. So for example, you might see ST segment elevations in 1 AVL, V5, and V6, but you're also seeing them in V2, V3, and V4. Okay, so that could mean that you have both the anterior and lateral aspects of the left ventricle have infarction. So that means that would be both the left circumflex and the left anterior descending. Now it could be that both are occluded, and that's why you're seeing the ST segment elevations. But it could also mean that if you see that much ST segment elevations in both those groups, that it could also be the left main. If the left main's occluded, it would affect both the circumflex and the anterior descending. Another one that I have not written here, which we should keep in mind, is ST segment elevations in V1 and V2 could also be an indication of a septal, what they call a septal infarct. So right around the septum of the heart, since V1 and V2 are the septal leads. So before I go through this case, I would suggest pausing at this point and seeing if you can assess this ECG for yourselves. Now, if we take a look here, if we look at our groupings, as we kind of talked about before, like our contiguous leads, 2, 3, and AVF, 1 AVL, V5, and V6, V2 through V4, and so on. Let's see if we can assess what's happening with this patient. And remember, we're looking for things like Q waves, ST segment elevations, or ST segment depressions. So if you look here, look at lead 1. All right, you can see AVL. Not so much V5, but maybe a little bit in V6 there. If our PR interval is our baseline, which is down here, you'll definitely notice that we have an elevation. Same thing in AVL, you see these elevations here in 1 in AVL, and maybe a little bit here in V6 as well. And so if we think about the placement of those leads, that suggests that there's an infarct in the left lateral wall of the left ventricle. And so of course, we got to look around too to make sure that we've covered everything else. We don't see any other ST segment elevations or depressions, which I don't see any here. But we do have other findings. So if we're completely assessing this ECG for new infarcts, we should also be keeping an eye out for any ones that were old. Okay. So for example, you'll notice that I notice a Q wave in AVF. All right, and if I take a look at 2, I also see maybe a 2 there, but definitely a Q wave in 3. So I'm seeing some Q waves here and there. I also see Q waves in V4. I see it in V5. Here's V3. All right, so V3, 4, and 5 have Q waves, as well as you can see a Q wave here in V6 as well. So remembering that the ST segment elevations suggests an acute or ongoing infarct, whereas the Q waves we don't use to assess acute infarctions, but instead give us an idea of possibly an old MI. So they're definitely having so far an acute MI in the left lateral aspect of the heart there, probably which is probably being provided by like the left circumflex, for example. Now, the Q waves, they're basically in the anterior leads as well as the lateral leads there. And so what that suggests is there was an old infarct in the anterior aspect of the left ventricle, as well as an old infarct maybe in the left lateral aspect of the ventricle. So So there might be some, some dead tissue that's in that area as well. So this is probably, it was a fairly sick heart who's had, MI in the past. Okay, so in this final segment, what I really just want to touch on is some other findings that you might have on an ECG and ones that you should look for, to kind of keep in mind as you're, reviewing. And of course, these types of findings are better suited within the clinical context of the patient, of course. But let's take one of the important examples, which is potassium levels. So increasing or decreasing potassium beyond the normal range can be very detrimental to the electrical activity of the heart, because it messes with essentially the Nernst potentials and so on, and changes resting membrane potentials and electrical activity of the heart. And so we need to be able to identify that quickly, especially if you have a patient in the clinic who you notice their potassium levels may be trending upwards, and you want to get an ECG to see if it's having any kind of impact on the heart, right? Because then you have to do some sort of an intervention. Now, with hyperkalemia, one of the classic findings is a peaked T wave. All right, so it causes that kind of repolarization abnormality. So you can see a peaked T wave. What can happen though is, if uncorrected, all right, the heart can go into fatal arrhythmias from it. And the peak T wave and the QRS can kind of get closer and closer together, and it can kind of start to form what they call like a sinusoid type wave, which can be very deadly. With hypokalemia, usually you have the opposite. There's flattening of the T wave and the development of something they call a U wave, which is another type of like repolarization abnormality there. So U waves you would see in hypokalemia, and typically the U wave is larger than the T wave, which, if there are U waves, that's usually the opposite. Usually the T wave is larger than the U wave. As far as calcium levels are concerned, hyper or hypocalcemia can cause changes in the ECG. And again, it's an ion that's related to the action potentials in the heart, so it does play a role. So in hypocalcemia, you end up with a prolonged QT interval. And just to remind you, the QT interval is the interval from the start of the QRS to the end of the T wave, and basically shows you the entire length of depolarization to repolarization of the ventricles. And the timing of that should, under normal circumstances, be less than 0.44 seconds. Okay, and again, we have to correct for that for heart rate and so on. So in this case, what you have here, and in our example, down here is the start of the QRS, and then the end of the T, and so that's the length of our QT, or our QT interval. So that's the duration, and it's prolonged in this case. And in the prolonged QT, the issue with that is something I've actually discussed in the prior video, is that when it becomes prolonged, the longer it takes for it to repolarize, the more at risk the person is for having another beat that occurs at the same time as it's trying to repolarize. So what you're seeing here is the T wave, and then you're seeing a depolarization occurring on top of the repolarization. So if it's happening at the same time, you end up with this pattern that we've talked about previously, which is a form of VTAC, like torsades, okay, the twisting of the points. So what you're seeing is these large amplitudes becoming smaller again, kind of looks like it's twisting. And so that sends the person into VTAC, which can be deadly. So they can be very dangerous. And so some of the things that can cause these prolonged QTs are long QT syndrome. It's an inherited syndrome, which I've mentioned earlier. But many medications can do it. So we have to be very sort of cognizant of what the patient's on when you're starting, especially new medications. You may have to get an ECG to measure that QT interval to make sure you're not increasing their risk for sending them into VTAC. So some of those medications are things like antibiotics, antihistamines, antiarrhythmics, psychotropics like antipsychotics, tricyclic antidepressants, antifungals, just to name a few, but there's quite a few of them. So you got to make sure you understand what medication the patient's on and what you're giving them, and it may require you to actually look at the ECG to make sure they're not at increased risk. So just in summary of some of the other ECG findings, here on the left, that's our normal our PQRS and our T. I haven't talked about this yet, but many people are on digoxin. Digoxin therapy characteristically shows this, what we call a scooped ST depression, and maybe some mild PR prolongation. And that's actually fairly standard as far as the treatment goes for digoxin, so as long as we're aware of that. However, digoxin toxicity can lead to ECG abnormalities as well. Hyperkalemia, you can see here the peaked T wave. Okay, severe hyperkalemia, as I said, can kind of turn into like a sinusoidal type picture, and the P wave starts to flatten, and so you're starting to see this picture here, and if it continues, again, it looks like it's sinusoidal. In hypokalemia, that's the emergence of this U wave over here, and the U wave can actually become more prominent than that T wave. In hypercalcemia, which I actually didn't discuss on the last slide, but hypercalcemia actually shortens the QT interval. All right, so that can actually shorten the QT interval. And hypocalcemia, it prolongs the QT interval. And again, with a prolonged QT interval, you increase the risk of VTAC or an arrhythmia. All right, so I'm going to end the session here. The next video will really be discussing an approach to ECG interpretation, so how to kind of take a look at the entire ECG as a whole when you get a 12 lead, and think about it in terms of the context of the patient, and what's the best sort of stepwise progression to make sure that I fully have assessed the ECG and I don't miss anything. So that'll be the next video, along with some practice ECGs.